How is everybody today? It's cold for Florida. So everybody wants to know a little bit about their speaker and who's talking. So the short story is I was a physical therapist for 10 years before going to medical school, did all of that practice predominantly out in Southern California. And then I went to medical school and did my residency in the Midwest, and then I came to Florida in 2014. And then in 2017, I decided to branch out and start a very unique practice where I go see you in your home. So it's a very different model, and I enjoy and love what I do. So today they've asked me to talk about advanced Parkinson's disease and how we manage that. So I always start from the beginning and the basics. So what is Parkinson's disease? It's a progressive neurodegenerative disorder. It's when we lose dopamine. We don't have enough in our substantia nigra, and that's really a downstream effect, right? So all of the neurotransmitters, we call it a whole brain disease. It's not only a dopamine problem. Because of how the brain circuitry is set up, you develop problems with all of your other neurotransmitters, and that's why we get all of the different problems we see in Parkinson's disease. So if you look on the left side of the screen at the yellow arrow, and you see those can't make this work, so that's okay. But if you see the little black area, that's where the dopamine is, and that's where the dopamine is stored in the brain. And if you see the blue arrow, and you see that there's really not any dark spots, that's a patient with Parkinson's disease. So you can see the distinct difference there. So what does PD look like? Well, all of these people have Parkinson's disease, and we know most of them, right? So the big thing with Parkinson's disease is there's motor symptoms and non-motor symptoms. Could everyone feel like they could adequately describe motor symptoms and non-motor symptoms? If I asked you, what are the 3 S's? Could everyone rattle those off quickly to me? Oh, I heard one, slowness. What's another one? Shaky. That's 2. You guys are doing great. What's the 3rd? Oh, those are some good ones. Speech, shuffling. Those are all signs of the problem. What are the symptoms? That's it. Very smart lady over here. Stiffness. So the 3 S's. And then we have a long list of non-motor symptoms we're going to go over. So I always tell my patients that Parkinsonism is a description. There's many causes of Parkinsonism, right? There can be vascular Parkinsonism. There can be drug-induced Parkinsonism. There can be the Parkinson's plus syndromes, right? MSA, CBD, PSP, all of those things. So Parkinsonism is a description. That's the 3 S's, stiff, slow, and shaky. Okay? You can have a 4th criteria, which is the loss of postural reflexes or low blood pressure. You must have slowness to have Parkinsonism plus one of the other 3. You do not have Parkinsonism if you don't have slowness plus one of the other 3 criteria. So that's where we start, Parkinsonism. Parkinson's disease is the most common cause of Parkinsonism. So in advanced disease, motor fluctuation usually start to affect people. So these fluctuating symptoms, right, stiffness, slowness, shakiness, start to affect people about 5 to 10 years down the road, right? We're talking about problems with advanced disease today, and that's our topic. So postural instability is a huge problem in advanced disease. Falls, a huge problem, right? Biggest cause of morbidity and mortality is falls. So we want to do everything possible to prevent that. Postural instability occurs right around 10 years after diagnosis. You start to lose your postural reflexes. This is the big one here. People who fall, Parkinson's disease patients, they tend to overestimate their abilities. And that's why I try to get people into physical therapy early. We try to establish a fall prevention program very early on. So what are the things that influence the risk of falls, right? We're talking about advanced disease today. One of the big problems in advanced disease is falling. So what do? So As a physician, I'm going to ask you these questions, right? And people are always like, oh, I don't know the last time I fell. It's important to me. And you don't need to keep a big, huge, long diary, but if you stick on your calendar, fell today, then you go back to the calendar when I come to see you, that really helps me. So we know people are at greater risk for continued falls if they've fallen in the past year. If their posture's like this, as opposed to this, you're at greater risk of falling. If you can't do the outstretched arm test very well, we know you're at greater risk of falling. If you have cognitive problems, we know you can fall much easier. If you freeze, how many people know what that is?
Yeah.
Most of them, right? I try to do it and show people when they don't know, but something like that. If you're weak and deconditioned, Parkinsonism doesn't lead to weakness, right? But if you don't get up and move and do what you need to do, you're going to become deconditioned and you're going to have what we call generalized weakness. Oops, excuse me. So those are all of the symptoms that we are concerned about, that I want to investigate when I see an advanced disease patient or even a patient at any stage in the course and process of their Parkinson's disease. So non-motor symptoms. These are all of the things that are not the 3 S's and orthostasis or loss of your postural reflexes or low blood pressure. Okay, so these are all of the things that occur in Parkinson's disease. So we see cognitive impairment, problems with executive function, that's the ability to make choices, decisions, different things like that, depression, anxiety, apathy, I just don't care, hallucinations and delusions, obsessional behavior, and all of these things you're at greater risk as the disease progresses and advances. Some of them you're at greater risk because of the medications, and some of them you're at greater risk because of the disease. And so medications and disease combined put you at greater risk. Fatigue. That is one of the hardest things to treat in Parkinson's disease, and we all struggle with that. And then all of our sleep disorders. And we know that some of these sleep disorders, like REM sleep behavior disorder, restless leg syndrome, those come on very early on in the disease course, but then they can become more pronounced, more significant, more severe as the course progresses. Autonomic problems, orthostatic blood pressure, your dopamine agonists, levodopa, those drop your pressure. Many times I'm able, as the disease progresses, to get people off their blood pressure medicines because of the disease course and because they're on levodopa and or a dopamine agonist. You develop incontinence, erectile dysfunction, constipation, that's an early sign. And then what happens a lot of times is as it's an early sign, we treat it, then a lot of us forget about it and we're not treating it, and then it becomes even more of a problem as the disease advances. So it's something you should always talk to your physician about. Nausea can be medication induced or as part of the disease as it advances. Sweating, temperature control, poor regulation. I can't tell you how many homes I go into in the middle of the summer and I have to take my white coat off because it's so hot in there because they can't control their temperature and they're very cold. So some more non-motor symptoms, they can be GI. I think we talked about constipation and nausea, but the drooling, loss of taste, that's an early sign, right? But then a lot of times people notice it as the disease progresses, even more pronounced. Dysphagia and choking, we want to always be aware of that. That's a question that should always be asked every time you go to the doctor visits. You cough or choke when you eat or drink. And if you notice it, you should bring your list and tell your doctor. Because we want to send you to speech therapy, we want to do those swallow studies and tests to make sure that you aren't having problems in that area. Because again, that can cause a pneumonia, it can cause all different kinds of problems. And reflux. And again, we should treat the reflux with all of the reflux medications if that's something you've developed. Sensory problems, vision changes. I like all of my Parkinson's patients to see an ophthalmologist. If you have an optometrist, that's fine. No problem. But you need to see an ophthalmologist at least once annually till the ophthalmologist says, I don't need to see you anymore. Okay? We want you to be followed by that because there can be different kinds of visual disturbances that develop, and especially as your disease advances. Maybe early on you don't need to see that ophthalmologist, but we do want you to see them as the disease progresses. Pain, especially with dystonia. Does everybody know what dystonia is? So dystonia is when your arm and your muscles get really stiff and stuck in a position. So you're like this maybe, or we see it a lot in the foot and it'll be turned in, especially in the morning when the medication has worn off. So morning dystonia is a big problem in advanced disease, and it can be very painful and very uncomfortable. So we want you to tell us about that so we can treat it. There's many great ways we can treat it, just to not allow wearing off during the evening and the night. And we know there are smell problems associated with that. Almost all patients have that. So treatment of Parkinson's disease, right? Just give you a little levodopa and you're fine. Is that how it works? Wouldn't that be nice, right? Oh boy. So this is where the art and science of medicine collide, right? So as your physician, I need to have the knowledge, that's the science part, and then there's an art piece that comes in that allows me to be creative and create different medication regimens for every single patient. I don't want my patients to all have the same regimen because every single patient is different, and that's the important thing, and that's the uniqueness of what I do with my practice. So, Michael J. Fox, we all know him. What are my treatment options? They're pretty simple. Medications, surgery, therapy, PT, OT, speech, and exercise. And I say exercise different than therapy. So what are my medication choices? I'm not going to tell you anything right now none of you don't already know. So there's no big surprise up here. This is all review. All of you people are sitting here because you're curious about advanced disease and have some basic knowledge. So this isn't anything. So you can all shout it out and tell me. So when do we start medications? Because we don't have a neuropreventative medication yet, right? So when do we start? When the symptoms bother you. It should be individualized like we've talked about. And the goal is the maximum benefit with the least amount of side effects. That's just a basic principle of life, right? That's pretty simple. And there's trial and error. I try to hit the bullseye every time. I don't. So we have to figure that out. And it's symptomatic. We don't have any neuroprotection. We're getting there. And I'm going to tell you what the best neuroprotection is. And it's a fancy word, and you're all going to love it, and you can all go tell your friends. All right. So what's different about treatment with advanced disease than earlier on? Well, dopamine production decreases over time. We all lose dopamine as a normal part of aging, but the curve of your loss is greater than the average person, thus you have Parkinson's disease. So, the receptors are also affected, the dopamine transporters, right? That's the DAT scan, we're looking at those receptors. And some of us think that perhaps if we are giving artificial dopamine, levodopa, then there is some effect to those receptors because you're getting pulsatile dosing, right? Because you don't have a continuous delivery system. So then that also affects and plays into this problem of dopamine production. We have higher risk of medication side effects, right? So as I increase the dose, you might have greater side effects. We have less storage, thus less release of dopamine as we advance in the disease. And so what do you need? More dopamine, right? It's a dopamine problem. So I got to give you more dopamine. But then there's side effects that come with it, right? And so then there's the vicious circle. So what happens? You get motor fluctuations, right? Dyskinesias, that's too much movement. That's at your peak dose. There is some rare events of wearing off dyskinesias, but in principle, it's peak dose. Medication wears down, you freeze, you're stuck, you're frozen. You're dyskinetic, you freeze, you're stuck, you're frozen. It's not a pleasant day, right? And then we also get worsening of the non-motor symptoms, and that's the thing that's forgotten a lot of times, right? So what's medication wearing off? Pretty simple. It's worsening of your motor and non-motor symptoms, right? Stiff, stuck, frozen, shaky. Those 3 S's, they get worse. Keep it simple, guys. Keep it simple. The 3 S's get worse. That's it. and then they improve with the next dose of levodopa. There's what we call dose failure, and that's a whole nother topic, but we like to distinguish wearing off from dose failure. So wearing off is you're better with the next dose, the medicine is working, it's just working for a shorter period of time. And there's predictable offs, and there's unpredictable offs. The unpredictable offs are the tricky ones, right? Predictable offs we can treat all day, every day, and we can be creative. It's more challenging, but we normally can get to it. And this is inevitable. As your disease progresses, you're gonna get wearing off. And that's where the art comes in. What do we do? How do we manage that wearing off? Why? Because you have decreased storage and release of the dopamine. What do? Higher doses of dopamine. Pretty simple, right? Only if it were that easy, right? We got to give you more dopamine in 24 hours. And then that's where all of these add-on medications come from, right? Because the levodopa, you develop the side effects from. So if we give you this medicine and it works here, and this medicine, am I going to prevent those side effects that I give you high doses of levodopa from? So what is a dyskinesia, right? Wearing off, that's at the end of the dose. Dyskinesia is typically peak dose, right? When it's the maximum amount of levodopa in your system. So it's abnormal choreiform, that's like dance, right? It's the Michael J. Fox look. You're squirrely all over the place and you might slide out of your chair. You might fall down, right? So it's too much, it's large, it's not small, like a shaking tremor, right? It comes from levodopa and it can affect pretty much anywhere in your body. So what are my goals in advanced Parkinson's disease? As your treating physician, what are those goals? What do I want to have happen? Number one, I want to optimize my on time. I want to decrease my off time. Okay, this is all common sense, right, guys? It's pretty simple. It's where the challenge comes in with each individual patient. We want to make sure your dyskinesias are as small as possible, and we want to control those non-motor symptoms as much as we can. So let's just go through the list of medications real quick. We have levodopa, and here's your long list, right? Sinemet, Rytary, you have oral dissolving tablets of levodopa. Stalevo, that's the levodopa with the entacapone added in. We have Duopa, and now the new kid on the block, Inbrija, and that's the inhaled powder form. And we're getting really good success with the wearing off. If somebody has a wearing off problem, this kicks in within minutes. My patients are loving it. That's a sample of the Duopa. It's a peg tube, it's a large cassette, but it solves a lot of problems because it's a constant infusion. There's the Inbrija, this is the inhaler here. You inhale it and you quickly have resolution of those symptoms, stiff, slow, shaky. Dopamine agonists, pramipexole, and the ER form, Requip, ER form, Nupro, and Apokyn. So those are our list of dopamine agonists. Remember, dopamine agonists cause a lot of hallucinations, delusions, greater risk of orthostasis, all of these problems. So I use them, but I use them carefully and judiciously, especially in advanced disease. Sometimes I'll pull a dopamine agonist as the disease advances and replace it with something else like more just regular levodopa because the side effects are becoming more of a problem. The MAOB inhibitors, we have the old one Selegiline, the new one Azilect. And then the newest one, Xadago. I use Azilect and Xadago. I use it in the beginning a lot of times with PD patients, and I use it in advanced disease as well as an add-on. The COMT inhibitors, entacapone, and the old one Tasmar. The new kid on the block, the A2A, and that's the istradafylline. We have the amantadine regular release and Gocovri the extended release, the old school anticholinergics, and a combination of those different therapies, right? And in advanced disease, it's normally a combination of all of those things we've just listed. DBS. How many people have heard of deep brain stimulation? Almost everybody in the room. Good. Good. So it's just commonplace. It's common knowledge now within that Parkinson's community, and that's what we want it to be. I think this is a phenomenal, efficacious therapeutic delivery system for Parkinson's disease. And all of my patients who are able, I like them to get DBS. So we're going to answer 4 questions in the 5 minutes I have left. Okay, what is DBS? Who should get it? When you should get it? And why? So, right? I'm somebody who keeps it simple. So it's what, who, when, why. Okay, so what is it? It's electrical stimulation to specific areas of the brain. We implant surgically into the brain, run the wires underneath the skin, and a battery in your chest, much like a pacemaker. We have 3 companies out there. We have Medtronic, that was the original. We have the St. Jude product. And we have the Boston Scientific product. There's advantages and disadvantages to all 3. I like the programming versatility that I have with the St. Jude product. So I'm introducing that product to a lot of my patients, although I cannot be product specific in a presentation. But all of them are efficacious. All of them are phenomenal delivery systems. So who should get it? If we're looking at the big picture, it's PD patients, ET patients, and dystonia patients. Those are the patients who can receive a deep brain stimulator. So when do we give it to our Parkinson's patients? When they start to fluctuate, right? Wearing off, dyskinesia is wearing off, dyskinesia is wearing off, dyskinesia is wearing off. There's a trial out there that was done. It's called the Early Stim trial. That shows if we do it a little bit sooner, not as a last-ditch effort, it's incredibly helpful to all of our patients. I love this slide. This is one of my favorite DBS slides because I think it tells the story so well. This is pre-DBS, and if you see this dark blue area, that's how the patients were with poor mobility. So we looked at mobility. That's all you guys care about at the end of the day, right? You want a good quality of life, and in order to have a good quality of life, you have to be mobile. So 73% had poor mobility before their DBS. After, the pie flips, and it's 74% had good mobility, and only 26 didn't. So I think that's a really phenomenal picture, and it really sets a good mindset for this therapy. And this is my second favorite, and it's not showing up as well on the slide, but the gray line is dyskinesia is wearing off, dyskinesia is wearing off. And I think when we go into DBS surgery, we have to set the appropriate expectation. You are not going to go from that gray line to a flat line, meaning your expectation shouldn't be having no dyskinesias, no wearing off. You're going to get some, but most people are perfectly happy to live with that yellow line rather than the gray line, right? So you're going to get some ebbs and flows, some ups and downs. And a lot of times success is measured by, did we meet our expectation, right? So if I set the expectation appropriately to you, you feel like you were successful. So we always have this conversation. We look at this picture and we say, this is the expectation. So where do we put it? There's this little place in the brain, it's called the subthalamic nucleus. It's that little yellow area there. That's one choice in Parkinson's disease, and that's the choice I like a lot. But there's a second choice that's called the globus pallidus, or GPI. So the STN, GPI, you probably heard that talk a lot. So we can put it in one of those places. The thalamus is for tremor. So physical therapy, occupational therapy, speech therapy, incredibly important in all phases of the disease process. So now we're getting to my favorite, because now we're talking neuroprotection. So PD and exercise, it likely helps with neuroplasticity, increases dopamine availability, and here's the new fancy word, BDNF. How many people have heard of that? Not one person is going to raise their hand. Tanya, you better raise your hand in the back there. So Tanya's sitting back at my table, and I know she knows and has heard of BDNF. So it's brain-derived neurotrophic growth factor, and this is what's released when we're exercise. We can't measure dopamine in the central nervous system, so if we draw dopamine from your blood, we get a number, but that doesn't correlate to the central nervous system. BDNF, we draw it from your blood, your serum, and it correlates to what we have available to us in the CNS. So we can measure it, so that's good news. Exercise improves sleep, mood, and cognition. So what is this BDNF you talk about? Well, it's a protein that's encoded on the BDNF gene. It's part of the neurotrophin family of growth factors. It's on chromosome 11, and it affects dopamine. That's why we care about it. It helps neurons to proliferate. Oh, that's good, because my neurons are degenerating if I have PD, right? It helps with synapse development, growth, and plasticity. That's even better. And it protects against neurodegeneration. Are you kidding me? Seriously? All I have to do is go out and run 5 miles and I'm protecting myself? Yes, you are. Absolutely. And it helps develop immature neurons. I did only 3.5 this morning. It was really windy here. Okay, so I think we talked about this, and so they were able to measure BDNF in the serum. Okay, 2014 study. These guys are out of Europe. The bottom line is these people exercise on a cycle ergometer, moderate training. So that's my advanced patients, right? You don't have to do high intensity, moderate. And look at that, and I forgot the S, UPDRS, that's Unified Parkinson's Disease Rating Scale. That's what those researchers use, that fancy thing when you go to the doctor, test this, right? They test your arm for stiffness, all that. That's part of that scale. We rarely get 10-point improvement with our medication trials and all of our different trials. Exercise trials, 10-point improvement, phenomenal. BDNF went up by 34% when these people exercised. It's phenomenal. I want you all to go out and exercise. But I want you to have clearance from your doctor, and I want you to have it designed by a trained person. So they say to me, what should I do? PD patients who exercise do better. Any movement is better than none, okay? I don't care what you do, just do something to move your body. You know that Madagascar movie, Move It, Move It, Move It? Yeah, you just do that. I have 2 kids. We watch all those kind of movies. All right, you got to be safe, and you got to get clearance from your doctor. Last but not least, I think this is what I hope you guys know, and I typically end with this slide. So people have seen me talk, see my 3 S's slide in the beginning, and then they see this slide at the end. And this is what I tell my kids every morning when they leave the house. And watch, it's for you guys too. Follow directions, right? They should listen when they go to school and do their things. They need to find out who their first responder is, right? Who's the first person I call in an emergency? Be organized. Oh my goodness, their desks at school. Oh boy. All right, trusted resources, right? Got to talk to the right people and know who to talk to. Get the most out of your appointments when you go to your doctor. Have faith in yourself. Ask for help. Don't let negative feelings get you down. Be adaptable. And I like the last one, laugh. So thank you very much for letting me talk. You have a good day.